Good afternoon. This is Nora McLaughlin, HFMA's Healthcare Finance Associate. Welcome to this HFMA webinar, What is the Difference and Why You Need Both, sponsored by Meridian Medical Management. It is my pleasure to welcome today's speaker. Claudia Maiorana is Senior Vice President of Customer Success at Meridian Medical Management. She has over 30 years' experience in the healthcare revenue cycle and customer success. She has extensive knowledge in the physician practice, academic medical settings, where she has managed large teams with exceptional ability to promote collaboration between groups while achieving goals in fast-paced environments. Brenda Lawrence is the Director of Revenue Cycle for Rutgers Health Group, part of RWJ Barnabas Health System. She has over 20 years' experience in the revenue cycle and system space. Brenda directs and coordinates revenue cycle activities to address the organization's needs to ensure compliance and revenue cycle efficiency. MaryAnn LaMarche is the Director of Solutions Management at PrecisionBI. MaryAnn brings 30 years of revenue analysis and business intelligence solutions development experience to PrecisionBI. She understands the unique challenges associated with healthcare data, and she focuses on the development of new solutions as well as related implementation and education processes. With that, Claudia, I'll turn the presentation over to you.
Thank you, Nora, and welcome everybody. Today we're going to cover 4 points. I hope you can see that, yes. The difference between denial management and prevention, the data needed to create a denial management plan, and we're going to talk about a case study utilizing the data, the analytics, the people, the processes, and technology, along with redesignment to manage and prevent denials at a real live group. We're also going to end with a 12-step plan for developing and implementing your own denial prevention and management plan. We're going to start with a polling question.
Does your organization currently have a denial management plan? Yes or no?
So we're going to let everybody answer that question, and we're going to continue along in the presentation. And as we look at the results, we'll pass on what we're seeing from the group that we have joined with us today. So as we all know, I'm going to state the obvious by saying, or maybe it's not so obvious to some, what we do in revenue cycle management is not easy, it's not simple. There are a lot of rules, there are regulations, they are coupled with people, training, systems of all kinds, processes, workflows, compliance risks, and all of these pieces change a lot. So it is complicated. We're going to try to unbundle a few of the complications and simplify them so we can work towards having a denial prevention and management plan for your organization. The piece we're going to talk about now is also ever-changing. We all deal with it, denials. We all get them, no matter how many claims you submit, no matter how much scrubbing you do. Most are paid, most are processed, but there will always be some kind of denial that we're going to have to address in one way or another. Not every claim will get paid. It's not going to get paid necessarily on first submission or after corrections or even after appeals. There's always going to be rework to do. The part of this presentation related to prevention is to take the first step in looking at your denial information and carving out those denials that are controllable by your group or your teams. After all, we're seeking payment for services provided to a consumer, a patient. We deserve to be paid, the group deserves to be paid, and the best that we can do is not only to know what our denials are, but to know why we are getting those denials and what the root cause is. So denials and the work to prevent them and manage them is the focus of our conversation today. So let's talk a little bit about the title, prevention versus management, and why you need both. The volume and opportunity, as well as the balancing act that you have to go through to understand what your return on investment is all relates back to the difference between denial prevention and management. Denial prevention it has a beginning and an end. It's a project. You're going to identify a particular denial, understand that that denial is caused by a gap, an error, a missing link in your revenue cycle process. So it's very important initially to approach your denial management plan as a project for your preventable denial. Somehow, some way, you have to understand the root cause and eliminate it, correct it, charge entry, redesign it, claim submission, scrub it. One by one, each of these types of denials that are preventable will have a beginning of your analysis and an end to it. And the end result will be that that denial will no longer be coming through your adjudication files. It will be clean claim paid because it contains the missing information that was causing the denial in the original project. If the denial is preventable, then you can figure out after you redesign the process, how do you continually monitor that that process is in place and working? And of course, that means looking at metrics and monitoring and measurement. We're going to talk a little bit coming up about what's worth sharing here, and that is some denials can be prevented. Some denials will need rework and an ongoing tight process for efficiently and effectively managing those denials, but all of them will need to be continuously monitored. For changes in volumes, category, payer rules, coding regulations, so your plan needs to address not only the prevention fix, but also the monitoring for changes to that particular denial or payer. So figuring out how do you go about doing this is something that we all face every day, and that is trying to balance what is it going to take to have a denial management plan that will recover opportunity, it will present revenue opportunities, that the work that you'll put into this denial management planning process will be will come back in less delayed cash and a cleaner revenue cycle. And obviously, it will help enhance the capacity of your workforce. So how do you get started? You have to know the challenges and embrace them. You know, the challenges that we all have in the revenue cycle business always involve, you know, time and resources and revenue and collection. You know, how do you balance these two? How can you get more capacity from your probably already at or over capacity staff? When you stop and think about how am I going to create this plan if I have to go denial by denial and figure out where the gap is, where the error is, the answer to that is you have to do it if you want a denial management plan that maximizes your reimbursement. So if you stop and work on this denial management plan, how do you keep your daily production work up? How do you ensure that the work that is being done and needs to be done today can continue uninterrupted while you do this analysis? Well, in order to have a denial management plan that is backed by your leadership, you need to prove that you need to do it. And the way you prove that you need to do it is to focus on a few examples, get some data, and estimate what the reduction of those denials would mean in faster cash, reduction of overall inventory that has to be worked, reduced days in AR, reduced AR over 120 days because your staff isn't able to get to those denials that need to be reworked faster. You need data. That's what it's all going to come back to, and we're going to talk more about that later in this presentation. The important point here is you have to make the decision to do it, and it's most likely going to be based on your revenue or collection opportunities. For example, if we spend X, we're going to get Y. and we only have to spend X one time and get the benefits downstream from the work that you put in up front. So in order to make good decisions, you have to understand what you're losing and what you could be gaining. To do this, again, you need both data and deep understanding of your revenue cycle process. If you don't have that on your team, that's part of the steps to creating a denial management plan that involves people at the source of the information that you're needing to look at. So the prevention initiative involves, as I've mentioned, looking at the process to figure out where in the process is the claim lacking the information that is causing the denial. How do you prevent a denial from occurring? You have to trace the origin of the source of the data entered on the claim back to the very beginning. So, for instance, an eligibility verification denial, it's either not done or the eligibility returned incomplete or inactive or incorrect or nobody followed up on it. That one's not too hard to go further upstream and figure out where it's happening. No authorization is another fairly straightforward denial. If you haven't received the authorization and sent it with the claim, it's going to be denied. But was that really no authorization obtained? Or could that be that the authorization number itself wasn't attached to the right invoice or claim? And in order to understand those authorization denials, you've got to go upstream or downstream and look at the process associated with those claims that are being denied. Procedure diagnosis code mismatch. Again, it seems fairly straightforward that that would be in the coding or the coding software or in your scrubbing software, but it may not be. You need to go through the provider diagnosis mismatch denial and create the improvement prior to the claim going out that there won't be a mismatch, and you'll reduce that denial. It's preventable. These are all denial types that you somehow can control, those three examples that I gave you, but I'm sure everybody on this call has many more examples. The key point here is that you have to look back. You have to go upstream from the denial as far as you can and map the process downstream to the denial, to the full adjudication. So we talked already about your authorization denials. Maybe it wasn't no auth on file. Maybe they obtained it and it wasn't attached. What's the current ownership to obtain the authorization? Let's say it's in scheduling. Is that the most effective and efficient place for the ownership of authorization, obtaining authorization? Should it be somewhere else? Maybe the front desk at discharge if there's a test ordered. What if they're too busy? We all know the front desk is probably overloaded. So again, making smart decisions. Where should it be? Should it be in nursing? Should it be a clinical function? Those decisions are all the decisions that are put on paper after you map the process and figure out where it's falling behind and know the actual root cause for the denial that is preventable. Not having an authorization is a preventable denial. You can figure out where and how to get your authorizations every single time. Human error aside, it is preventable. So start with the denial type and map out the process along the full revenue cycle. And when I say denial type, you know, you're not going to look at every single denial. You're going to look at the denials that relate to eligibility, the denials that relate to authorizations, the denials that relate to coding or bundling or duplicate. You're going to have to get the data that will show you those denials and then work through the process for each of those types. And again, you can start small if you don't have a big team, or you can start big and assign full categories to teams of people, or you can assign one denial type as a prototype and possibly put that prototype together for a presentation to your leadership to show them that there is opportunity there and you need resources in overtime, temp resources, reallocation of capacity. You need their support to help you get the information and redesign the process to ultimately reduce your preventable denial. So again, it's complicated. You know, it involves people, it involves processes, it involves departments probably outside the control of some of those on this call. It involves leadership, it involves time, it involves collections, revenue, forecasting, projections, and it is an opportunity for everyone. Automation and system technology aside, they can scrub and they can put edits and rejections on lists for you, but nonetheless, if you have a very clean denial rate and you're still getting scrubbing errors or upfront edits, you know, prior to claim adjudication edits, you still should work on a preventable denial and reduce those two areas. So it's not just fully adjudicated denials that are preventable, but also edits and rejections that are prior to adjudication. So, oh yes, it is complicated. So in your process work, learning each piece of the claim, the charge, the billing cycle, be open to creating a redesign if needed. And what I mean by that is, as we mentioned before, your authorization or duplicates or procedure code mismatch, procedure code diagnosis mismatch could all have the same area where that information is missing or the failure in the cycle is occurring, but maybe that's not the best place for the fix to occur. Maybe it would be better for the fix to occur in a further downstream area prior to adjudication. There could be opportunity in any case to obtain or validate the authorization in any other location. So be open to looking across the root cause location and the solution location. And included in that solution location, of course, is enhanced system technology or automation. Both of these areas are, talked about in all of the revenue cycle conferences that we go to and in our own user groups. You know, how much better can the practice management technology be or the EMR technology be to point out areas of opportunity for downstream denials? Can any of these denials, which are routine, can your practice management system build automation that will handle some of the more common daily occurrence type of denials? For example, an eligibility denial or the status of a claim. Those are the types of things that you can explore with your system vendor, what kind of automation they have, what kind of enhanced technology they have to prevent denials downstream. Because we all know reworking denials costs a lot of money. So the key point here is to know all the input stops and to be open to changing instead of fixing or vice versa. Fix instead of change or enhance. So your prevention plan needs to have data. You can start with a payer or a denial, as we mentioned, one denial or one payer. You all know the denials you can control, so pick one. Map it from start to finish and call in the teams to confirm your process map is accurate. Very important to get them involved. There's a lot of things that a team lead, a manager, a director, a VP might not know in the current operation, and it would be definitely a team building as well as an improvement opportunity for communication and accurately documenting your current state. Then brainstorm. Where is the area for improvement? Can it be made here or there? As I said, there could be more than one area where you can stop that charge from going on to claim and put the implement the fix, the improvement, or the redesigned workflow. And then it's rinse and repeat for each denial category after the first one that you go through. And the first one will be probably slightly painful. You have to document, you have to discuss. There could be disagreements about where the fix needs to be made, but ultimately the communication will lead you to the right answer. You want to be the most efficient, that means as quickly as possible, and the most effective. Who are the people that can ensure that this missing piece of information creating the denial can be implemented and ensure that it's not missed? Eventually, all the denials that can be prevented will be prevented. They'll be going out clean. They'll be getting paid. Your overall AR follow-up inventory will go down, and there will be less touches on claims submitted. So you did it. Now on to the management, because once you get through your prevention at the beginning and an end, as we talked about, once you get through that prevention, then you've got to ensure that you've cycled the prevention denials. You create a loop to measure and manage any leaks. You, for example, a new payer has a new rule saying you have to submit a procedure with a new modifier. You need to go back to your process and see where do you implement adding that modifier. So denial management is making sure every denial that needs rework is worked with the lowest amount of touches in the shortest amount of time. You got to know where the best place to send that denial for rework is. Send it to the experts to research that denial. If you don't feel like you have experts, then get them training and train them to be experts, whether that's by payer, by specialty, by denial type. However, you have to ensure that the denials that can't be prevented upstream, that are going to come back asking for additional information or missing information, or it's a duplicate, or it needs an appeal or a corrected claim, make sure they go to the people who know how to work them. Then create a workflow for each of those denial types that need to be managed. And again, do the same thing that you did with prevention. Bring the team together. Document the workflow for reworking that denied claim. Assign it to the best people, or enhance your technology and or reporting and or automation to give you an edit list or send an automated work queue to the right team. So now that you've done prevention and management, you have to put it all together in a plan, because you've probably all talked about doing prevention and management of denials, but having a plan means you have a documented policy and procedure that is going to say who owns this denial plan, what is in the plan, where is the plan located, where does it show new employees or current employees that need to make a change, where can they go and see what the workflow is. Can you build the workflow into your practice management system or into your inventory management system? Can you build a process and a workflow and teach your teams to follow that? So go through these questions and create this document that will encompass all the denials that are preventable and the policies and procedures and workflows that you developed to ensure that you're managing all of it. Monitor it, measure it, report out your metrics. Make sure you have a baseline. Show your before denial rate and your improved monthly denial rate. Stay on top of it. Someone has to own it, and make sure that that someone has a feedback loop when they see what is in your denial prevention and management that's leaking through, that there's a good feedback loop. All of this work starts with data. In order to do it, you have to have reports and data. MaryAnn LaMarche is going to speak to how to best gather that data and create the information necessary for your denial management plan. MaryAnn, you can take it away in one moment. I just want to show everybody that the created poll for does your organization currently have a denial management plan? 73% of you said yes, you have a denial management plan. 14% said no, and 13% of you either don't know or you're not sure. So MaryAnn, go ahead.
Thank you, Claudia. So as Claudia mentioned, where do you begin? And of course, the answer from my perspective is with the data. You need to understand your data in your system so you know where in the processes you have opportunity for that improvement. So here's my analytics design process for working on identifying those denials. The first thing that you need to do is you need to assess your practice management system. By that I mean you need to understand how the data goes in, how the data comes out. Not all practice management systems are created equal. Some systems I've worked with only output denial codes. They have no descriptions, they have no categories. It makes it hard for you to understand your data when you've only got a very limited view into it. So you may have to see if you can customize your PM system to some extent by adding descriptions and categories. You may have to add flags for primary or secondary denials, or you may have to do that on the back end in your analytics database. But wherever it is, just make sure that you've done that assessment so that you know what you're getting into before you start trying to pull out your data. Step 2 is about categorizing and segmenting your data. In order to better see the problem areas, you need to do some categorization of like denial codes, types of denials that are actionable versus non-actionable, as Claudia mentioned earlier, or pulling out the informational denials because the informational piece may give you some information, but you may not be able to collect on that. It may just be an information or remark code. You may want to further segment into things like front and back office related denials so that you know where in your offices to focus improvement activities. And you may want to also segment them or categorize them according to functions like scheduling, coding, or billing. The third step is really to define your requirements associated with the reporting that you're going to do on denials. And importantly, write them down. You want to think about the inclusions and exclusions. It's easy for us to say, I'm going to capture a denial code and put it on a report. It's a little bit more complicated when you think about the things that you want to include or exclude to make sure that you're getting good, accurate, usable data. Do you want to look at all your denial categories, or do you want to just look at certain denial categories, like the actionable ones, or even a subset of actionable or preventable denials? How are you going to handle the data in your system associated with things like charge corrections or void transactions? What about your PQRS charges or your $0 charges that are in your system? You need to pull those out because you don't want to account for charges that you're never going to get a denial for. When you think about recovery, you want to think about things like payment or transaction codes used in your system, and even certain amount fields that come out of your system that may represent patient responsibility, like deductibles, co-pays, or other patient payments. When we talk about recovery, we want to understand the recovery coming from our payer. And also, will you look at things like only the primary insurance, or will you look at primary, secondary, tertiary payer recovery? You need to think about all of those questions when you're putting your data together. Step 4 is to define some other requirements around sifting out the data, like the time frames you're going to want to report by. You can do time frames a couple of different ways and for different metrics. It may include activity-based. That means the date the denial was entered into your system, or collections-based, where you're matching the denials up to the date associated to that original charge or invoice. For collection-based reporting, and especially around recovery, you're going to want to consider what kind of lag time you need when you're looking at your data. Your charge is going to go out the door at a certain time. Payments are going to lag by a certain number of days, weeks, months. So think about that when you're building out your time frames. And then lastly, what kind of rolling month trends will help you to monitor your improvements over time? Do you want to look at 12 rolling months or 13 so that you can see the same month in 2 different years? Step 5 is really look at the levels of aggregation. You want to aggregate your denial data to focus on problem areas within the organization. So look at things like which departments or service locations, payers, providers, and denial categories you can look through so that the information pops out at you. Step 6 is, now that we have our overall requirements and timeframes and levels of aggregation, is to really define the specific metrics. And some of that's going to be dependent on the level of detail in your practice management system. For example, what are you going to count as a denial? Some systems you may want to count invoices, some claims, some charges, some units, counts of denial codes. It'll depend on how your system is set up from a level of detail perspective, what things you want to count. So in addition to how will you count things, you want to also know how to define denied charges. When a charge gets denied, are you going to look at the gross charge? Are you going to look at the charges less the contractual adjustments? Are you going to look at allowed amounts? Do you need to consider any partial payments that came in with a denial? And what's your definition of recovery? Payment post-denial, or will you look at insurance payments and adjustments post-denial? 7 is to use an analytic tool to build out dashboards to help you easily identify those top problem areas in your organization. Basically, the who, what, where, and when. And then assess the trends in the top problem areas for improvements. Focus on top 5 or 10 so that you can keep those biggest issues in front of you as you start working through improvement processes and working with those preventable denials. And then lastly, continuously monitor your dashboard so you can celebrate your improvements and also adjust for changes in processes and or new regulations and rules. The next few slides, I'm just going to show you a few examples of dashboards associated with denial management. This first one is just a quick example of an overview that talks about some of the things that I've mentioned previously. How are my denials trending over time, the dollars that are recoverable, what CPT codes have the highest recovery ratio, top 5 denials by category, by codes, by groups and divisions. These are the questions that you want to be asking. This is an example of knowing what denials are occurring. In this example, we've got denials categorized into groups: coding, duplicates, medical necessity, eligibility, authorization, and timely filing, and enrollment and other denials. And for each one of these tabs, we look at the top 5 denial codes within each. And you can see pretty clearly certain things pop right up to the top of those dashboards, so you can easily see what areas you need to work on. Here's another example of knowing where your denials are occurring. You can look at it by your department or division or your service location. Looking at your denied services by category is helpful too. The slides are probably a little bit hard to see, but they're CPT codes down the side, and again categorized by each major code of denials that we're looking at. Coding, medical necessity, duplicates is the one that we're looking at on the left, and on the right, eligibility and authorization. Again, it's pretty easy to see which things are popping to the top in each one of these areas. You also want to monitor your recovery. This is knowing what your outcomes are. So look at your denial trends over time. What's my denial rate? Which payers are being recovered? How many dollars are being recovered? It's great to know how many denials that you have and to be able to count things, but really at the end of the day, we all want to know how much money we can recover through those costly efforts of working our denials. And lastly, here's an example of just monitoring your denied services. This one actually will show your top 25 procedures where you've received recovery, and also a look at some of the insurances. So these are just some examples that you can look to use in your own organizations. And with that, I'm going to ask another polling question. Based on what we just learned, do you think you have the ability to obtain the data required to begin analyzing denials in order to start a denial plan? And with that, I'm going to move on and let me introduce to you, turn over to Brenda Lawrence, the Director of Revenue Cycle at Rutgers Health Group, who's going to share with you a real case study using analytics, people, and design process redesign to reduce denials and improve cash. Brenda?
Thank you very much. So, I'm just going to talk a little bit. I think I have 4 minutes here. Just to reiterate what Claudia said, categorization is everything. We have, unfortunately, tens of thousands of denials every month, and that's because we're talking about multiple denials per CPT transaction. Could be anything, remark codes, those kind of things. And to be able to categorize the type, is it an eligibility issue, is it a provider enrollment issue, and even down to the location, so that you can assign the responsibility. Again, the front end responsible referrals, the back end responsible for the authorizations, things like that, so that we can move forward quickly, identify issues before they become $100,000 worth of, lost money because they haven't been appealed quick enough. So some of the things that we've done are the actionable items. Things like we take the provider enrollment denials, and every week we match that to an ongoing list that we share with our credentialing vendor to make sure, did we make sure that when Dr. Smith is, on the list with Horizon NJ Health and that they're fixing it, and what's the status when we meet with the credentialing vendor, what's the status with Dr. Smith, instead of, it's hard to quantify when it's a 1 or a 2 thing, but if you know that you have to deal with your provider enrollment issues, because these carriers will drop your physicians if they don't pick up a phone and say, yeah, I'm still here. So that thing we've learned the very hard way, and we have a really good process going forward for that. The other things are coordination of benefits. Here in New Jersey, we're expected for our main carrier, Horizon, to let them know once a year, yes, here's our coordination of benefits. We don't have any other carrier. They literally will not pay a claim until the patient or subscriber does that. So we have a couple of months of charges that just sit out there and are denied, and all we can do is flip it to self-pay and wait for the patient to call and say, hey, you need to do this. What we did was we made it, we enabled the system to automatically insert a statement message. So yes, still gets flipped to self, but it's telling the patient they need to do this. That saves a phone call to the back end, and also hopefully we are seeing some success. Hopefully that makes the patient do what they need to do. Again, actionable items are everything to us. Let's see, what else do we have? We use the claim scrubber and the denials for coding errors and denials to build ad hoc claim scrubber edits, so that every carrier has their little quirks, and yes, there's claim manager, higher level carrier edits, but then we're able to build these little edits that say, Horizon really wants a 25 modifier when this scenario occurs, even though it's not necessary, it is necessary to get paid. So you're able to take those denials, say, I need to build this. You can even do some things we've done with auto action, so you don't even have to touch it. It doesn't stop at edit, automatically adds it, and you can go forward. I'm at my time, so I'll turn it back to you, Claude.
Thank you, Brenda, very much. Okay, the next slide, I hope, kind of pulls it all together for everybody. We've talked about prevention and the process to get to the lowest number of denials overall that are preventable. And Brenda brought a very good point up in terms of actionable. Can you do something about it? And that might be an even better question to ask when you're looking at where should I start? Is there something that you control on your team that you can start with to improve or redesign a workflow that currently does not capture the prevention for a particular adjudicated denial? And of course, technology, scrubbing, software, enhanced to the point that it's really working for you is also something that should be part of your overall denial management plan to ensure that your scrubber rules are as updated as they can be to your particular specialties and business. So we end this webinar in terms of the presentation material with a summary of everything that we've talked about today and a step-by-step process that you can utilize to begin to put together, or as the polling suggested, many of you have a denial management plan. And you could utilize these steps to ensure that your denial management plan that's existing today actually covers everything it could cover. And if you have a denial management plan and your denial rate is 10% or more, or even 5 to 7%, you have an opportunity. So I encourage everybody to go through these steps, compare it to what you have in place today, and utilize these structured directives to get to a comprehensive denial management plan that includes continuously monitoring for prevention opportunities, as well as managing the denials that have to be reworked. So with that, I'll give you the results of the second poll question, which was based on what we talked about today. Do you have the ability to obtain the data you need to put it into the buckets and the categorizations and to look at your recoveries in a way that is at a high level and then a drill down perspective? And 79% of you believe you have the data. 21% of you don't think you have the data. So again, I would encourage you to go through these steps, and if you don't have the data, which is the first step, obtaining the data, if you don't have the data, you can start manually, depending on the size of your practice. You can start with just posted denials. You can start with EOBs. You can, be more sophisticated with your remit files. But you have to have a denial management plan if you're going to effectively optimize your reimbursements and if you're going to have a streamlined workforce associated with AR follow-up. So with that, I'll leave 10 minutes for questions and answers, and hopefully we have the answers. And thank you, Brenda and MaryAnn.
So I just want to send a reminder, if you do have questions, please enter them in the Q&A box or located on your computer screen. And the first one is it acceptable? What is an acceptable denial rate?
So obviously that's a pretty loaded question, but less than 5% is an industry standard number. And let me tell you a little bit about how that's calculated, because it makes a difference. 5 to 10% is the average respondents in most of the industry metrics that we look at, but less than 5% is better performing. The calculation is total claims denied divided by total claims submitted, and you do that for a fixed period of time. So for the previous 3 months, 6 months, 12 months, 2 months. Take all of your denials divided by your claims, same period, period over period, and that percentage is your denial rate at the highest level. As MaryAnn mentioned, you could also, and Brenda mentioned as well, you could take your denial categories and figure out where are most of your denials, where's the highest denial rate or the highest volume of denials that you're facing, and start there.
What would be a denial type to start going with to get going? Would it be eligibility, non-coverage, or something else?
Well, again, I think that that's a great question, because it's the first question you're going to ask. Where do I start? And I think depending on the team that you're on and the type of denials you're receiving, you could either go after denials that are high in volume that you have control on the process for. So eligibility is a good place to start. If you're getting a lot of eligibility denials, you obviously, you or your practice, your group, somewhere controls the registration and eligibility verification for the patients in the practice. If you control that process and you have a good upstream knowledge of where it should occur or is occurring, you could start there if that's a problem denial for you. If timely filing is a problem denial for you, if you're sophisticated enough that you've really hit most of your preventions and you're you're managing your rework denials well, your days in AR are low, your aging isn't building because of denials that are not yet worked, you could focus on timely filing denials, and you could break that up into timely filing submission denials, which you would probably have control of that, or timely filing appeal denials. Did you miss the appeal time frame for getting that claim reprocessed? So it really depends on the data, and the data will point you in the direction you should go. But again, if you want to start with what you have control of, that would be your best possibility for success.
Okay, the next question is, I'd like to understand how you identify preventable versus non-preventable when a single remit code could be preventable for one payer and not for another payer. In addition, a combination of remit and reason codes could signal one scenario being preventable or not. Are you looking at the possible combinations to report or simply assigning on the remit code level?
That is a great question. I can make an attempt, but MaryAnn, maybe you would be better, maybe you would answer this better than I, because you've done so much work in setting up dashboards and looking at the data underneath. Is that something you want to take, or would you like me to take it?
Why don't we tag team that one? So,
okay.
From the perspective of data, we can certainly look at multiple levels of codes. So a particular code along with another code is certainly something you can capture data for.
So, and I'll add on to that. If you have one rejection code that can mean two different things for two different payers, you're going to have to go down to the level of that payer and what it means, what the denial means, what the reason for that denial is for that payer who is using that denial code. So my suggestion would be, when you have multiple reasons that are different across payers, because that's where it would be, across payers, I'd go to the payer level for each and work them as an individual preventable. If it's preventable, so the difference is, if you can prevent the denial from occurring in your revenue cycle controls, then it's preventable, and that's what we mean by that. If you can do something to ensure that the claim doesn't go with the missing information or the reason that you're getting the denial, then it's preventable, and you should figure out how to control it. If you don't have control, of the denial, then I'd put it in the inactionable and figure out if it needs to be managed or it can be controlled. Yes, MaryAnn.
Just to add to that too, is once you can identify which is preventable for which payer, there's always the opportunity in your analytics data to set flags at the payer level and at the code level to easily tickle those out as needed.
Right. Yep. Brenda, did you want to comment on that one? I know you've run into one rejection code means two different things for payers. Anything you might want to add?
Oh, they change it all the time too. So I mean, you just take buckets and then you get a task force together and you break it out. And some things we create what I call dummy rejection codes. So there's a prefix on it so that I know it's coming from Horizon versus something else. Because we need to quantify that as quickly as possible. And then, yes, when we categorize, it all rolls up, but then you drill down into our dashboards and you can see the detail at the code level. And then you're saying, oh, look, there it is, Horizon again. Sorry, I don't mean to badmouth Horizon. But that's how you do it. So, yes, you need to drill down. You need to have the task force. You need to look at it from the inception of the charge, the data entry piece, all the way down. Is it a problem with the data entry piece? Is it a problem with the claim scrubber? Is it a problem with the way the claims going out the door? Or is it a problem with the way that the denials come in through the door? We have lots of times where a carrier will send us a denial and they'll pay us at the same time, 2 different transactions. So we waste our time looking at those.
Good point. Thanks, guys. Any other questions, Nora?
Yes, this is a 2-part question. It says, how much of a factor does professional training and certification play in this role? And how much support do you receive for professional training?
Oh, boy. Well, I'll start. So I think most of the certification or deep knowledge that's needed would be around the coding denial. And I think all coding denials, you would need certified coders who have experience with the latest regulations and possibly even be, super certified in a subspecialty. If you're talking about, orthopedic hand surgery versus, family practice E&M coding with 25 modifier, 2 different levels of deep knowledge that you need. But I'd say from a coding perspective, you do need professional certification to sort through what is preventable, what is clinical, what is strictly coding related, and if it is preventable or if it's just going to go out and be bundled and there is no rework. So that's what I'd say on that front. In terms of all other types of denials and professional certification, I don't think that there's, certainly it would never hurt to be a certified, CPE, CMPE, or to have a certification for medical billing. But if you have people who have been working in your department and know the processes, it's very important to understand the current state, even more important than the future state in some cases. The current state work that you're going to do to map your workflow or process for a denial is probably best done by the people who are actually performing the workflows and the processes. To get your current state diagrammed and documented means that you then have the opportunity to look over it, maybe with more knowledge or different knowledge than the current state folks, to say, well, where's our opportunity here? Why is that happening up there? Why can't we move it down there? So I don't think professional certification is necessary for working through this process, except for the coding and clinical type denials.
Okay.
Was there another part to that? Did I miss another part to that?
No, that's great. And we have one more question. It says, what is a typical percentage range of denial success rate of getting payment?
Denial success rate. Okay, so I'm going to assume that means you have received a denial and you've submitted an appeal. And from an appeals recovery perspective, the latest numbers I've read out of MGMA, Elizabeth Woodcock, is 65% or better is successful appeal recovery rate. And I'll just add one thing to that, and that is if you're not receiving 65% recovery on your appeals, then you need to either work with your payer or stop doing the appeals. So I would really recommend diving into that appeal recovery rate if it's not more than 65%.
Okay. At this time, I'd like to ask our speakers if they have any closing remarks.
I'd like to say thank you to MaryAnn and Brenda for joining me in this webinar, and obviously thanks to all who have attended. And if there are any questions, I believe HFMA moderator will give you email addresses where you can ask questions beyond what we heard today.
So we have reached the conclusion of today's webinar presentation. I would like to thank our speakers for presenting and Meridian Medical Management for sponsoring this very timely webinar. We hope you have found the presentation informative. If you have further questions about this webinar, you may email them to the HFMA Resource Center at resourcecenter@hfma.org. Our Resource Center staff will assist with questions not answered during this webinar. Thank you again for your participation and have a great day.